just sort of say, hey, I'm more nervous than I think the other Mary is because I'm really not a public speaker. But the one thing that I do know is hospice. So this should go pretty easy, and I guess if you want to ask questions during, that's fine. Otherwise, if you want to save them for the end, that's good too. I've been asked to talk about some triggers for hospice appropriateness. And one of the big questions that I see all the time, and even when I look at my patients for hospice, is, would I be surprised if in 6 months they're still here? Usually if your answer to that is that yes, you would be surprised, that's when we start looking at hospice. There's several things that we're going to look at through this, and a couple of the slides that are in here are more informational than anything else. But we're going to look at some of the signs, not so much with the disease, but factors that will lead up and help give you a diagnosis to make somebody appropriate for hospice. All right. We look at some of the referral triggers in the hospital. When I go into the hospital and I'm seeing patients, I may not have a clear-cut diagnosis on a patient. So I'm looking through their histories and I'm looking at things such as, are they having symptoms that are interfering with their quality of life? Have they had a decline in what they're able to do, their functional capacity? Were they ambulatory, out, up, doing their own thing, and now all of a sudden, mom or dad's wheelchair bound, having trouble, can't cook for themselves anymore, unable to get to the bathroom, things like that. Are they having weight loss? And by weight loss, we're looking at greater than a 10% weight loss in the last 6 months. We may not think of that as a lot, but if you look at somebody who normally only weighs about 100 pounds, and they've lost 20 pounds in the last 6 months, that's huge. If they have several other comorbidities, such as diabetes or heart disease, if they have wounds, if you're seeing them coming in and out of the emergency rooms or in and out of the hospital, and if they're having recurrent infections, urinary infections, upper respiratory infections, if they've had sepsis, any of those type of problems all add to a hospice diagnosis. I put in here at the beginning of this a couple of assessment tools, both a FAST and a palliative performance scale. Our FAST scale that we use, and I'm not going to go through all this because most of the clinicians already know the FAST scales, but what we're looking at on a FAST scale is primarily for our dementia or our Alzheimer's patients. When we're looking at a FAST on a dementia patient, this goes all the way through 7F, but a dementia patient needs to be at least a 7A level to meet end-stage dementia. They need to be to the point where they can only speak a few words a day. You know, if you look at when they're in the 6s, they're incontinent. They're incontinent in the bowel, they're incontinent in the bladder. They can be, let me word this right, they can be incontinent and still speaking, which means they've never hit that 7A level. Incontinence alone doesn't qualify you for an end-stage dementia diagnosis. So you can't jump around on the scale and go backwards and forwards. It needs to be a progressive decline, but dementia patients do need to be at least a 7A.
Can I ask you something?
Absolutely.
What if they are unable to walk anymore, but they're still speaking some? You know, more than 5, 6 words a day?
Well, then you would go to the lowest of that number as far as where they meet.
Okay.
So you can't jump it just because he can't walk, which would be a 7C, but he's still talking.
Okay.
He would still.
Okay.
Talking, and it is different from a meaningful conversation. Can you have a meaningful conversation with this patient? Speaking, but in their own little world, most of them, like badly, gets in that mode.
Okay.
It's a meaningful conversation.
So they can say words, they just have to make sense.
Yeah.
Right.
It's like if I ask you what color the sky is and you're talking about your dog next door, you're not connecting.
Right.
You know?
And so that doesn't, speaks 5 or 6 words during the day, I can still be at that. I can still be saying those words if they're not making any sense.
Correct.
So you're really looking at, do those make sense? Guys, one thing I want to point out here, one of the reasons, and some of y'all heard my speech on this, one of the reasons that the Medicare has really come down on not using dementia as a diagnosis for hospice as much was because in their studies over the last 5 years, what they've discovered is that putting somebody with dementia on hospice generally doesn't save the Medicare system a lot of money. And the reason is that by the time somebody has that much memory impairment, then we're automatically saying, don't do aggressive treatment. And so what will happen is you take your mama to the doctor, and the doctor will say, well, I'm not going to do surgery on her because she really doesn't have her mind and it really doesn't matter anymore. You know, I encourage you guys to really think through this process, is that sometimes just because I can't remember or I can't communicate doesn't necessarily mean I should be withholding medical treatment from a patient. My dog doesn't communicate very well sometimes, and my dog doesn't understand what's going on, but I still get the health care treatment that's needed. You know, so don't put people under unnecessary pain. But a lot of physicians and a lot of families will just say, don't do anything because she has no quality of life. So that's a whole long conversation that you can really have with somebody as well. But the real key for us in the hospice world is trying to find, are there other diagnoses for that?
Absolutely. I put this together too off of one of the websites, and just because I could not, for the life of me, get everything I wanted on the screen, I'm not computer literate, but this is the PPS, or the Palliative Performance Scale. We use this on every patient in there, and it's basically a scale that goes from 100% down to 0. 100% meaning there's basically no disease going on. 0%, if you notice, is death. It doesn't get worse than that. So as you decrease in your PPS level, you'll notice that people that are having normal activity all of a sudden are unable to do things such as clean house or work or anything like that. And you also notice that the confusion levels and their mentality changes as well. They go from being ambulatory, doing what they're normally doing, to being bedbound. So it's a natural progression of the disease as it goes on. We do expect both this and a FAST scale as patients on service to decrease. I put in here a couple of the different prognosticators that we use, some of the main disease processes that we look at when we look at hospice, and just a little bit of history. My history is both oncology and cardiac. I used to teach CHF and work with the Joint Commission at one of the other hospitals. For compliance and everything on CHF, I love cardiac patients. Absolutely love them. And they're very unpredictable. But when we're looking at cardiac disease, we look at somebody who has actually been optimally treated. And when we say optimally treated, we're looking at patients that are on maximum med therapy. We're looking at ACE inhibitors to promote heart function. We're looking at the ARBs such as Coreg, Norvasc, any of those. And we are also looking at a diuretic, being on board for a nitrate, such as nitro, some for chest pain. All those medicines, even if a patient may not be using his oxygen all the time, et cetera, they need to be on max med therapy to be a true end stager. Anybody that is end stage cardiac should be treated fully. So they're looking at all the different medicines. They're looking at whether or not a patient's a candidate for surgery or not, if they're on a heart transplant list. If they need open heart and they're not going to do it. We also look at a New York Heart Association scale on them, which is usually a class 1 through 4. Class 4 being a patient that's short of breath at rest as well as on exertion. These are your patients that'll be sitting there talking to you and are short of breath, just sitting there. They can be a class 3 with advanced cardiac disease. Class 3 is usually your patients that are short of breath with exertion. But as long as they're on all the correct meds, a New York Heart of 3 will get you a hospice diagnosis. They also put in there, a lot of the literature says that they're looking at an ejection fraction, which is your heart function, of less than 20%. However, the more I've looked, it is not a true requirement. It helps, but it is not an absolute requirement for hospice. You have patients, depending on what side of heart failure they have, they may have ejection fraction of 60 or 65%, being right-sided failure, and still be appropriate for cardiac disease. I know you're, no?
It's 20% less than normal, so it's 70% is considered normal, so you're 20% less than that, and that's positive. It's not PF 20%, because you're pretty far gone with the 20%.
Absolutely, that's why I'm saying it is.
That's not, yeah. Yeah, 20 to 25.
It's in the indicator, the little prognosticator books. I think Melissa has one of those in her.
It helps support it, yeah.
Going sort of hand in hand with heart disease, you have pulmonary disease. These are your people with COPD, pulmonary fibrosis, pulmonary hypertension. You're looking at your patients once again that are having disabling dyspnea at rest. So they are short of breath, just sitting there. They're starting to have decreased functional capacity, which means they're having trouble. They may have been up walking around, now they're bed to chair bound. And it's basically because of shortness of breath. And there's a chronic cough on them, and that's due to the lung disease. They may be continuing to have exacerbations of either COPD or pneumonia. They could have right-sided heart failure or core pulmonale related to the COPD. They're looking at resting tachycardia of greater than 100 a minute, which most of your lung patients are going to be tachycardic anyway. And also, they're not absolutely required, but most of your COPDers are going to end up having weight loss. They're also going to have hypoxemia at rest, and that's on room air. Most of your COPDers are going to be on oxygen continuous. A lot of them are non-compliant. As long as you document it, you're fine with that. Another one of our diagnoses is strokes. Strokes are a little bit funny just because the more I see them, they all present so differently. A person can have a stroke and have right or left-sided hemiparesis and still be very functional. Doesn't necessarily qualify them for hospice. So we're looking at somebody who's no longer, because of a stroke, able to care for themselves, having problems with getting intake, whether it be related to dysphagia, disease progression, not wanting to eat at all. You could have post-stroke dementia. And when you're looking at that, you're looking at a person that now is no longer able to ambulate. They're not able to bathe themselves, cook for themselves, do any of their normal ADLs that they were able to do prior to the stroke. Having a problem with communication. So once again, here we go. with not having anything meaningful as far as communication. Their PPS score, you're looking at a 40% or less. And then other triggers for it could be that they're having aspiration pneumonia now because they're having a dysphagia from the stroke. Upper respiratory infections, ulcers that are coming up, fever that's recurrent even after antibiotic use, and then being over 70 years old. It's one of the criteria that help with a stroke victim, because usually your younger stroke victims are going to rebound a little bit quicker. Cancer. Cancer's a very easy disease to figure out. You're looking at people that are no longer getting treatment. They have stopped chemotherapy, they've stopped radiation, unless they're doing radiation specifically for palliative reasons. Whole different conversation. But if they are not seeking curative treatments, they're not getting any further chemo radiation, and they are not on any sort of trials, clinical trials, they would be appropriate for cancer. You're looking at a metastatic disease. You're not looking at a stage 1 breast cancer. You're looking at somebody that the cancer is spread. And that if the disease progresses on its natural course, it will cause death. Dementia is one of our other ones. You're looking, once again, a FAST scale of 7A or below. They're now needing help with ambulation, bathing, feeding. Not ambulatory, they're incontinent. They may be starting to have problems with dysphagia as well, because these are the patients who, as their disease advances, you're expecting to see that they're going to have problems with swallowing. You're expecting possible infections, UTIs, pneumonia. You're looking at weight loss from not being able to eat. And a lot of our late-stage dementia patients are also getting pressure ulcers from now being bedbound. There's a couple more slides on here for some of our main diseases. And I think we actually have clipboards with the prognosticators and all this on that we will be giving y'all later so that you can have them. Renal disease, patient cannot be on dialysis. We're looking at people with a creatinine greater than 8, 6 for diabetics, or creatinine clearance of less than 10, 15 for diabetics. They should have, a lot of your renal disease patients, you're going to see comorbidities such as COPD, CHF, it's huge in renal disease. A lot of times I see our congestive heart failure patients come in, they're getting dialysis, and we're getting a referral for renal. However, they're all intertwined. So if they stop dialysis, we know that the natural progression is they're going to fill up, they're going to get toxic, they're going to decline. So we can't do dialysis on those. If they're having intractable fluid overload that's not responsive to treatment, paracentesis is a prime example. A lot of them will be getting paracentesis. We'll do them within a week, fluid's coming right back. So they're really not working on them. You're looking at decreased urinary output, usually less than 400 a day. The other thing is that patients can be on a transplant list and still be considered for hospice. However, when it gets to the point where they get accepted for a transplant, at that point they come off. Liver disease is along the same lines. You're looking as far as the ascites, the swelling in the belly that's not responsive to treatment. You're looking at albumin levels, 2.5 or less. Most of the patients that we see going in and out of the hospital are going to have either hepatic encephalopathy that's not responding to treatment, some sort of hepatorenal syndrome, and they're going to have either malnutrition, maybe alcoholism, maybe some hepatitis. They're going to have some sort of comorbidities going on, or they're just going to be straight out non-compliant. They may have recurrent variceal bleeding, and this is another diagnosis where they can be on a transplant list and still be eligible for hospice. ALS, which I don't know where, I think up in Greenville they get more than we do, but ALS patients, we've seen a few down here, and usually they're coming from the Greenville area, and they're sick. I mean, really sick when we get them. You're looking at their vital capacities on their breathing less than 30% of normal. Usually with ALS, you're going to see a rapid progression. It's sort of, every time I see this, it reminds me of something like Lou Gehrig's, where it's just a progressive muscular disease. And usually breathing is going to be one of the biggest factors as far as what's being affected. You're going to see repeated infections in these patients, significant shortness of breath at rest, even with oxygen. Patients are declining artificial ventilation. A lot of them, though, we will see that'll come to us on nephrology machines. And we've had them, and we've still kept them on hospice, because without that machine, they're going to pass. And you will also see a continued weight loss, because as this disease progresses as well, you're going to see the problems with dysphagia.
So Mary, you're saying that the trilogy meds kind of before was considered kind of like sustaining, but we've done that more.
We've had several on them down here, too, that I know of that have been on the trilogies, and they don't use them all the time, but just at night. And we were able to maintain them even with that, because without it, yeah, it would have been probably hours. We don't see a lot. We do have our HIV patients. They're looking at the CD4 counts on a patient needing to be less than 25 cells per MCL, or a viral load that is persistently greater than 100,000. In addition to the CD4 count, they need to have one of the following. So they need that, and they need either a PPS of less than 50 or equal to 50. And then one of the other symptoms, such as wasting, Kaposi's sarcoma, unresponsive to treatment. So they need to have some sort of other comorbidity going on with them beyond just the CD4. So after all of this, when's the time to make a referral to hospice? You're looking at your patients, you're seeing your patients all the time. They have made multiple trips to the emergency room. Condition may have stabilized, but the illness is continuing to progress. And it's affecting their quality of life. You've seen them, they've been admitted to the hospital numerous times over the last year with the same type or worsening symptoms. Patient wants to stay at home, doesn't want the hospital anymore. Or patient has decided that they're no longer going to get treatment for their disease. Hospice doesn't hasten, it doesn't postpone death. Death's going to happen regardless if a disease progresses. At this point, what hospice is truly looking at doing is providing the services that a patient needs so that the patient and the family can be able to have a death that's acceptable to them. At the middle of hospice belief is that everybody has a right to die pain-free and with dignity. And that we are able to provide our patients and their families the support that they need